So, a quick introduction. I am Joe Morrison with Right to Breathe, the founder and CEO. And on our call today is we have several of our board members, Michelle De Silva, our Director of Education and Respiratory Therapist, Allison Morrison, who's actually my mom and also an RN. Um, and I don't see John Linnell on the call yet. I'm surprised. I know he will be joining us. And John Linnell is one of our board members as well. And I am really excited to welcome Dr. Keith Robinson to the call. Um, Dr. Keith, oh goodness, we met at Pulmonary Horizons how many years ago? 3 years ago, maybe?
Oh
No,
gosh, more than that.
Yeah, I
way
think it's
more than that.
I think it is more than that. But I have followed along as Dr. Keith has been doing several things. I have a tremendous amount of respect and admiration for what he does in the respiratory space. And I'm going to just let him take over from here because I think you'll see by his presentation that there are some things that he has done within the world of paying attention to pulmonary rehab and exercise, which are among really the best things that can be done. If I'm not mistaken, it is proven to be the most effective way of treating COPD for sure, as well as other respiratory conditions, is pulmonary rehab. And now that pulmonary rehabs are well, some are opening up and some are not, I think this is a great time to have this conversation in order to see, continuing in our series of focusing on movement and activity. I think this is a great way to kind of cap that off. So without further ado, I'm going to mute myself. And Dr. Keith, the floor is yours, sir.
I appreciate your time. Everyone, please remember to stay safe during the winter months. I heard 18 degrees. So I want to make sure that I at least start by stating that I hope you all well. Please stay safe during this early part of the pandemic, and I hope to see you at another chat on the opposite side of the winter. I'm happy to be here with everyone. I've had kind of an up and down year, as most of us have. I unfortunately had to close the rehabilitation center where we were working and transition towards expanding what we were accomplishing, simply because, again, the number of people who come to rehab was small to begin with, but once the pandemic hit, that absorbed, unfortunately, our ability to continue. But I think the things that I place in this deck are the things that we learned since we opened in 2013. And I think a lot of it has to do with the lessons learned. I trained in San Diego. I trained with Dr. Reese at UC San Diego, who wrote one of the first books on pulmonary rehabilitation. So I was happy he was my faculty advisor. And one of the challenges that we often grappled with was getting people in the front door, as you know. The other was getting people to continue to do activity after they left the rehab. And then the third was the most maybe obvious to us, but maybe not obvious to the people who came to us for rehabilitation, was how do we continue that level of activity and make it a lifelong endeavor, not something that you do over 8 weeks or 12 weeks or 16 weeks dependent, but something that becomes a part of your lifestyle. So lifestyle changes were a huge part of why when I had an opportunity to open an office, and I opened it up specifically as a pulmonary rehab center in South Florida, we really wanted to do things that were best practices. More importantly, we were listening to the people who came to us and telling us that they didn't have a gym fix moment, so they weren't going to become marathon runners. They didn't have a Jane Fonda tape, so aerobics were almost certainly not something they were interested in doing. They didn't own a bike, so they probably never rode a bike, or at least not since childhood. So we started thinking about how we couple activity with things that people can do that don't require equipment, but more importantly had the same exercise benefits that you would get if you'd gone to, say, the prototypical pulmonary rehabilitation center, where you've got not just your education and nutrition component, but your exercise component involving a treadmill, which we did have. We had our treadmills and bikes. But I think we learned in 2013 when we rented space out. We rented space out in the summer months because it gets too hot in South Florida for folks to do Tai Chi out in the park. So we invited a Tai Chi instructor to lease that space from us. And I think over the period of the 2 months over summer, I recognized a good number of my patients had migrated from coming to the treadmill and riding the bicycle towards waiting for the Tai Chi instructor to be present. And that opened my eyes, because I think when subjects and patients start to migrate towards activities that they find comfortable, first, but second, enjoyable, then I started looking to see what other things we could involve in our rehab that were going to be lifestyle changing, hopefully, activities for folks. I'm hopeful that some folks have not had to go through this process, but the cycle of COPD and chronic lung disease, it can be pretty arduous. And I think what this slide hopefully shows is that we recognize that when you get short of breath, that's what exertional dyspnea is. That can lead towards being more immobile, which may lead towards more increased shortness of breath, which may lead towards losing some muscle, which unfortunately decreases your ability to get up and do activities. Most common activity would be the things you need to do every day: brush your teeth, comb your hair. And then, once you start losing the basics, then the physical activity falls off, meaning the idea that you would get up and take a joyful walk down the beach becomes a task that would be scary for some. So this vicious cycle is something that in pulmonary rehabilitation we've tried at every level to try and stop, get the cycle to stop, so that again we can get patients to a level of care and more importantly away from disability, so that there are more qualified parts of the day. More importantly, the quality of life folks can go up, and then more importantly, people can be participant. We forget oftentimes that folks with COPD, at least 2/3, are under the age of 65. And so for us, that means they're still trying to get out the front door and go make a living. And so the idea that COPD can be this insidious and rob people of their quality of life as well as their productivity suggests that anything you can do on a daily basis that's comfortable, that's easy to maintain, will affect this cycle. Now, this comes out a little blurry. I tried to blow it up because I knew it was going to be a little hard to see small, but what it shows is the amount of time that people with COPD spend versus healthy people spend in a day. And I think if it's not easy to see, what we're showing is that folks with COPD, any level of COPD, spend a good chunk of their day in sedentary behavior. Sedentary being sitting, lying down, doing something that's physically inactive. And that's a sad thing to show, because I think when we compare those to folks of the same age, which this slide used, people who didn't have any chronic lung diseases, while they were still a little bit more sedentary than folks a little bit younger, they still felt as though they could get up and do the things they needed to get out the front door, get to Target, get to Walmart if they needed, and have a qualified afternoon without feeling like they were going to be too winded and more importantly, too short of breath and lose days because they exerted themselves too much. So we recognize this early in COPD, and I think even before COVID-19, we knew that the ability to get out was limited. So I'm imagining that the current viral and weather has probably accelerated that concern for many. And so the rest of what I'm going to demonstrate in the slide deck is hopefully to remind that we know that getting out can be a scary thing to do. We know that it can tax you. And so the idea is finding that level of activity that benefits, but also provides you the level of energy left to not only make it through the remainder of the day, but to get up the next morning and still feel as though you didn't run a marathon like Jim Fix. So this slide is just kind of a reminder slide. I think the things we know about pulmonary rehabilitation, if you've had an opportunity to go, is that the whole goal is not just to teach you a little bit about your COPD, make sure you're using your inhalers correctly, make sure you know what your rescue zones are: green days, yellow days, red days. But we look specifically at making sure we can get your exercise or your endurance training up, get the strength training high. COPDers have a difficult time using their upper extremities just because you need some of those muscles to help you with breathing. So the idea that some of our training was specific to helping those what we call accessory muscles were a huge part of what we tried to do in our rehab. The other things we did was try and give activities that folks can do at home. So the benefit of pulmonary rehab is it can be done anywhere. And I think that's maybe the double-sided part of my coin, which was even though I wanted folks to come in the front door to visit with us in our center, a lot of what we were trying to instruct in self-management was the opportunity to learn what we could offer, but to take those things home and to do them over and over and over again to a point where, and I hate to say it, that sometimes folks never came back because they got so good. But that's the whole goal of pulmonary rehab, is to really launch you as high as we can with exercise endurance and strength endurance, so that the things you do at home can be done repetitively. And again, we find that when you can do these things on a regular basis, it reduces stress and anxiety. And we know that anxiety and depression unfortunately goes hand in hand with chronic illness. And so COPD being a chronic illness, it's not uncommon to find some folks who have a good degree of anxiety related to their breathing. But I've highlighted in yellow what I think is the most important part, which is that I've found that even now in 2020, patients wait too long to go. And so even in our ICUs, we're starting to do as much as we can with getting people mobile, because we know the earlier you get active after an exacerbation, the sooner you're going to get better. More importantly, the less functional decline you'll experience when you're ready to go home and start your recovery. So the recommendations currently are to start after a hospitalization within 4 weeks. And I know sometimes that's a hard task to do, especially if you don't make it directly home. But the sooner you're able to get to a qualified rehabilitation center, or at least begin a really what I would consider a quality rehabilitation program, one that involves not just education about your disease state, but offers some level of nutrition advice, some level of support, and I think this pulmonary support group might suffice for that, then you're going to be on a better track than if we had done nothing at all. So symptomatic patients, and we know this now rather specifically, which is the sad part of rehab now being closed in so many locations, is that even subjects and patients who have not had a large degree of lung function loss, so patients who are still actively smoking, their exercise tolerance is nowhere near as good as folks who have never been smokers. So the suggestions that you have to have a large degree of lung function loss in order to unfortunately qualify for pulmonary rehabilitation is not true. And so we oftentimes will find patients who have just chronic bronchitis, so still normal lung function, but their exercise capacities are not where they should be for their age, and they qualify for pulmonary rehab. So every patient with some level of symptoms related to their breathing should qualify for pulmonary rehabilitation. Thought there was a question. I saw a little hand pop up. You know what? That's my hand. Never mind. Let me move that out of the way. So here's where I think our office centered. And, I have to, in all fairness, give some kudos to my wife. She's a chiropractor by training, but we shared an office. And I think some of the things I learned through that first decade of our working together was that a lot of the things that I suggested to patients from at least a COPD standpoint, a Western medicine standpoint, while they made people better, they weren't the things that people were looking for. So when we added her services to the office, and I'll go through some of those in a second, I found that people came to our office for more than just rehabilitation. It became a place where they sat and talked. It became a place where if they had pain, we know arthritic conditions are the number one comorbid problem, meaning other disease problem that patients with COPD have. So if you've got achy joints, seeing somebody who can help with the pain without having to use a medication like a morphine or an opioid was beneficial. And I think I learned that after my very first day in office with her, when she noticed one of my old COPD office patients had stumbled off a treadmill and found that he had to take a Vicodin in order to come into the office that day so that his knees wouldn't hurt. And so she worked really hard with getting his knees to a point where they were not as hard on him, and more mobility, hard to say. And I think the idea that when we think about CAMs, we're thinking about the other things that people are taking, other things that people are doing to help them make it through the day. So CAM is short for complementary and alternative medicines. So when we talk about it, we talk about a diverse group of therapies, whether medical or healthcare related, practices, things that people do, and products that people will generally not associate with, say, taking an inhaler, getting a prescription at the pharmacy, getting an injection, so getting some level of intervention by a clinician. And so CAM is the term that we use for medical products and practices that are not part of standard medical care. And so the new term that we're using in pulmonary rehab and in functional medicine is integrative medicine. And so if you look for integrative medicine clinicians, you're likely to find that they use a good degree of CAM as an alternative to Western therapy. And so I throw that out there because I think I'm finding that there are a large number of integrative medicine clinics, functional medicine clinics that are developing, and I think as we move forward past this pandemic, they're likely to be the foundation for how even some folks with COVID-19 who unfortunately are going to be disabled on the back end are going to get back to a qualified and more productive life. So, I think I've answered this question, but, why, will we put complementary and alternative medicines in a pulmonary rehab center? And I think that, again, the long-term benefits that we know about pulmonary rehab is that they tend to wane at about a year. So the benefit you got in the first couple of months of therapy, if you haven't kept it up, you could expect that a year from the day you first went to pulmonary rehab, it wouldn't be the same. So the idea was that we wanted to demonstrate that when we can improve capacity, we needed to make sure that that improved exercise capacity translated into more physical activity. They're not the same. So having the capacity to do exercise is one thing, and we know from COPD studies that patients don't really lose their capacity. They just lose their will for physical activity. And so if we can convince patients that they still have a normal capacity, even though they don't feel as though they can get up and down the stairs like they used to, they're more likely to be more physically active. And I think that's the first part of an inhaled therapy, is helping the lung to ventilate and breathe as best it can. But once your breathing is improved or your inhalers are working, that's the moment you want to get up and try and get your exercise capacities up, so that, again, you're able to do more physical activity. Because, again, the decision to get up off the couch is the physical activity, but the ability to do a lot while you're off the couch is your exercise capacity. So for my baseball fans out there, I used to say in my office, I'm going to get you up at the 7th inning stretch so you can get to the beer at the fridge and make it back without feeling too winded and short of breath. But I think the idea is that the whole idea behind getting CAM into PR was we were trying to relieve symptoms at the same time that we were improving quality of life. Back to my office patient who had bad knees. So there was a need for an outcome measure, and unfortunately, our FDA hasn't quite stepped into that realm yet, where they accept some of the outcome measures that are available that tell us that the modalities I'm going to show you in a second work. But the idea that they've been demonstrated across multiple populations, from China to India to South America to here in the United States, suggests that, again, they're good modalities. They've got science behind them. They do improve life, and more importantly, they do increase physical activity, because each one of the activities I'm going to show you is an activity. It's not something you have to think about. You're certainly going to be active in what you're doing. So some basic examples so that you're more familiar with the broader term of CAM. Most folks have used a vitamin. I think many would be surprised to find that close to 90% of folks with COPD and asthma use at least one type of CAM on a day. So botanicals, depending on where you live in the country, that could be medicinal CBDs or THCs, the marijuanas that might benefit with pain relief and anxiety concerns. But mind-body therapies, these were the things my wife brought to the office. So hypnosis, a good buddy of mine who's a nephrologist brought the yoga. And I think for many of our folks who had difficulty with gait and standing, we did yoga in a chair. So systems of stretches and poses and breathing techniques that, again, benefit patients with COPD, but yoga is an activity. And I'll show you some interesting data about that. And then Tai Chi. As I said, we had the benefit of having a Tai Chi instructor, Qigong actually, I should be more specific, Qigong, come and utilize our facility for about 2 months. And, we found everybody that participated went home, and even to this day, if I've had opportunity to see Tai Chi in the park, I might see one office patient who's still out there almost 10 years later, still participating. But Tai Chi and yoga, they're things you can do at home. They're great YouTube videos or videos that you can be supplied to demonstrate all of the motions and movements. They take about 15 to 20 minutes in yoga at the shortest, that's chair. Tai Chi is about 30 minutes to 40, depending, again, on which kata, that's the type of activity you choose. And they can be done at your pace, so gentle, slow. But I think the benefits of both those activities well outweigh any exercise equipment you would have purchased, treadmill, bike. I like whole body vibration machines, but you don't need to buy any equipment to do yoga or Tai Chi, and they have just the same amount of exercise benefit with the benefit of also giving you an activity that you can do every single day. Some of the other things that my wife brought were manipulative therapies. So massage, oh my gosh, we had more people coming back for massage. But I think the idea that, again, a lot of people had some limitations and more importantly, had some flexion and extension concerns that made their walking gait a concern. And more importantly, their balance a concern, was a reason why I was happy that she was capable of providing that level of care. Again, pain relief, non-opioid pain relief, acupuncture was her thing. Again, she was a chiropractor, and we learned actually for some of our folks that by just straightening the spine, for some who unfortunately became a little hunched over with their COPD, just straightening the spine improved their lung function. And I can explain that later if a question comes up. But I think the idea that sometimes the musculoskeletal limitations that you have with your disease can be corrected, and that might also, without medicine, improve your ability to breathe more comfortably. And then reflexology, pressure points, trigger points is what you would call them. They can be little parts of muscles that have a little tension, and you focus in on those areas and relax them, that again help more patients have mobility and more importantly maybe sit upright and stand upright so that they could walk more efficiently. So she brought efficiency to a good number of the folks that we were treating in our office. So these are all those activities. Believe it or not, stand is an activity. We know that if you stand more during the day, you're going to live longer than patients who sit all day, which is a rather funny thing to find out. But we know that from people who have to work and stand all day, that they do a lot better in long term than if they have a seated job sitting at a desk. But I put in red here the thing that most people don't think about. We call them stealth activities. It's generally the things that you do in preparation for something. So if you've ever had to meet with friends and consider doing, say, a breast cancer awareness month walk or an asthma walk, for many, you prepare for that. You don't just hop up off the couch one day and decide I'm going to go walk 3 miles with my friends. You typically will do practice runs with them, whether it's just a 16 blocks or shorter. But the idea is we know that in those stealth activities, the things that you're doing to prepare for another activity, those are activities, meaning you actively thought of getting up, getting out the front door, going to do that activity, and you did that multiple times so that you could participate. And that's what I like about stealth activities is that they are ways to prepare yourself so that you can participate in other things that are going on in life. And so, we in South Florida, our lung association, we like to get people to come and participate. And so we often will have events. And so I offer that to you to look for those events where you can participate by either showing up, and showing up is walking because you got to walk out the front door, or actively participating if it's an asthma walk, if it's a pulmonary fibrosis walk, if it's a COPD climb. So the idea that you can prepare for those stealth activities means that you're actively getting involved and participating with the community of folks that are just like yourself with symptoms and more importantly, some level of chronic lung disease. But the other things I put on here, activities of daily living, Tai Chi, we've spoke about yoga, Pilates, we've spoke about. Whole body vibration is a device, it's a machine, but it also has some clinical benefits. We've had a good number of patients who unfortunately were balance concerns, and using our whole body vibration device allowed us to, without having them to actually walk or sit upright on a bicycle, stand and allow the gentle vibration of the vibration machine to improve their exercise capacity, and it certainly does work. And then last is dancing. I'm hopeful that we'll get to a point in time where we're all going to be able to get back with family and turn on the music and start dancing with our loved ones. And so don't forget that dancing is a great way to get active. And so if you were a dancer younger in life, I would suggest picking it back up because I think there's going to be lots to dance and celebrate once we get into the spring. So just a little bit of data. So I know there's some respiratory therapists, and you may remember this if you've been to any of my other talks, but I think what's important here is that, again, Tai Chi has been demonstrated in a large number of populations now across the world to be beneficial. So those arrows that you see on the right slide are really specific to the data. The 6-minute walk distance, many if you are using oxygen therapy, you've probably had to do a 6-minute walk. And so all the things in parentheses are these clinically significant improvements. And those up arrows suggest, again, that these are measurements that we could do within a pulmonary rehab office that are often within the literature that tells us not only do these activities work, they work really efficiently. So what I have on the left side are the two different types of styles of Tai Chi so that you have a little of information. So Yang style was something we offered that's closest to Qigong. It's short, but it's the most popular form that you'll find on the West. And then the Sun style, it really, I think for our patients that are mobility and challenged and maybe a little more frail, because that one doesn't have as many katas, but it has more length in how long you hold the pose. Just kind of a little pearl. But they're all considered moderate activity. So for anybody looking to get better, you want to find a moderate degree of activity in order to get out and get active. Yoga, as I said, again, another modality that has the ability to operate at a moderate level of physical activity. So the posture changes are called asanas. The controlled breathing are called pranayamas, excuse me. And so the idea is that not only are you learning about your posture, you're feeling where you are comfortable and uncomfortable, but you're doing controlled breathing. So the mindfulness of how you're taking a breath in and how you're exhaling that breath allows for you to really think about your overall condition so that you're able to feel the improvement as well as help you to hopefully, what we find in some patients is that they ventilate really well. In fact, breathe much, much better after doing yoga sessions than they did before. So what we find here is that the amount of air you can exhale in 1 second, we call the FEV1, increases rather significantly, as well as, again, the distance walked or ambulated can increase with just doing the gentle activity of yoga. As I said, some folks are balance concerns, and so we do recommend a chair yoga where you do most of your activities either seated or you do them with holding onto the chair for balance control. But again, we don't want you to do these activities if you've not had opportunity to at least have someone assess your balance issues if you do have balance concerns. But I think the idea that breathing stamina, relaxation, calming the body, all those things have been beneficial in COPD. And this is, again, another physical activity that gets you up and out of the front door to hopefully get better. Again, you don't need to go to a facility to do yoga. You can certainly do it at home. I mentioned acupuncture with my wife, so I thought I'd at least include that here. So there is some good amount of data that suggests that we call it needling, that by needling certain musculature and nerves within the thoracic cavity relaxes those muscles. And so if you can make the thoracic cavity, the rib cage, less rigid, that allows for you to ventilate more efficiently. And so if you can reduce muscle fatigue associated with how you're breathing, you're likely to complete more activity and complete your tasks without feeling like you had to stop. So that would be what we see here on the right side, the improved dyspnea or shortness of breath, called the Borg score. So if you've been to pulmonary rehab, you're certain to have had somebody measure your Borg score, which is how short of breath are you feeling with each activity. So we can demonstrate improved breathing. Oxygenation, I didn't see that same benefit, but the literature suggests that some patients can improve their oxygenation with acupuncture. I'm not going to make that bold suggestion. But the SGRQ, which is what's called the St. George's Respiratory Questionnaire, it's a quality of life questionnaire. The significance of dropping by -16 is dramatic. So for most folks, if you drop -4, meaning you're improving, then that suggests that you had whatever intervention worked really well. So to get to -16 in the literature is really, really good. So again, if you've had musculoskeletal injury, musculoskeletal pain, acupuncture becomes a great, safe, non-opioid way to mitigate the pain, but also maybe improve your walk distance by having thoracic activity by a qualified acupuncturist. Then last, I mentioned whole body vibration. As I said, we had a vibration device, and for our folks that were truly spinal and more importantly, balance concerns, this is what we would use at least to get them started so that, again, they weren't fall risks on the treadmill if they elected or fall risk if we had them on the bike that wasn't recumbent. So they're two different settings, a static and a dynamic. The whole point behind the vibration devices, which you actually can purchase at a nominal, I wouldn't say nominal, $150 is a lot, and that's a low end. But I think the idea that, the ability for this device to help you to improve your walk distance, improve your quality of life, improve your exercise capacity without actually getting up and actually walking 2 miles. And more importantly, it improves your bone mineral density, so it helps mineralize your weakened bones and improves balance in older adults. So I think, if I had to pick a device that anyone had to purchase and not something really overtly expensive, again, I know $150 is a lot, it would be the one device that I would pick over a bike or even a treadmill. So with that, there are pitfalls. I, as a physician, always want to make sure that everybody knows the red flags. There are lots of things that are offered as complementary and alternative. The most glowing one for me would be stem cells. I recommend to everybody that I meet not to do stem cells. There's no data behind it. There's no recommendations from an FDA or a regulatory agency. It's just, unfortunately, some folks have taken to the fact that stem cells can work in some conditions, but it hasn't been demonstrated to work in COPD. So avoid anything that promises a cure for COPD. As you know, unfortunately, once you've lost lung function, that lung function's gone. You want to make sure you want to tell your doctors that if you're going to meet with another clinician or functional medicine clinician, that you've at least discussed it with them. There's no such thing as a secret therapy. I've heard some of my prior patients tell me they were told there's a secret therapy that they're going to get online, and I say there's no such thing. But talk to your doctors. I think the more of your clinicians you can involve in your decision to use complementary and alternative medicine suggests, again, that you're being proactive in managing your condition and not waiting for doctors to dictate to you exactly what you require to get better. So I would avoid any clinician who absolutely doesn't want to talk to you about how to get to a functional medicine or integrated medicine physician or clinician, because that suggests that either they're not familiar or they're not comfortable. And if they're not comfortable, find a doctor who is, because I think that is going to be how 21st century medicine moves forward, which is we treat the whole body not just each organ system that's in dysfunction. So those clinicians, I think, are going to be the forefront of where we go in the next decade or so in medicine. But again, I've said this multiple times, and I'll say it last time, make sure you talk to your doctors about participating. I want to make sure that, again, from a safety standpoint, if you've never had a good qualified evaluation to ensure that you're safe for doing physical activity, that you've at least had your doctor take a look at you, done an EKG, make sure your lung functions are safe, make sure from a physical activity standpoint, you're not at risk of having anything bad happen. Once you get that okay, then I think a lot of the activities that I demonstrated here are not only safe, they don't require equipment, and more importantly, they'll get you back to being physically active. And the most important thing for me is that it becomes a part of your lifestyle. Once these activities become part of your lifestyle, you've got something new, something just yours. You can share it, obviously, with family, but it becomes a thing that you own. And I think that's what COPDers, at least in my prior practice, were looking for, things that they could own as they've had so much robbed from them due to the, unfortunately, loss of productivity, either due to work or due to the illness itself, COPD. So I think that's my last slide. And I will answer any questions that have come up since I've started yapping at everybody.
One of the questions that was in the chat, and because I've actually never seen as well, is the whole body vibration machine. So I don't know if there's a way to describe what that is, and it's something that I've heard of, but I've actually never seen one.
Let's see if I can. I'm going to try and. So I'm going to move something over. You're not allowed to see half that stuff, so let me close it out.
There were a few folks that came in, and I muted as you came in, so I can unmute some of you folks here. And if someone and other folks have a question, if you've muted yourselves, then
Can you see my screen still?
Yep, we still got your screen.
All right, so these would be similar to the devices we had in office. They look like a scale. And again, I don't want folks to feel like they have to go out and purchase equipment. That wasn't the point. I think the whole idea was that we get to a point where people can't get out because of the cold, or we get to a point where folks can't get to a facility. Something as simple as some of these are really like this guy's a really expensive one. I don't know that you need something that big. Some of them are quite small, and I think let me go back to. Yeah, you can see how expensive they get, but something, simple. Again, I'm not offering or advertising on Amazon, but you can look for them, and they offer different modes. But you can see, this one's $149. You can get some for $80. Again, I don't want folks to spend money unnecessarily, but I think the idea that in pulmonary medicine, you already have so many expensive therapies, so many expensive things that we're asking you to purchase. My goal is not to recommend you go out and buy a whole bunch of stuff, but there are cheaper ways, less expensive ways to maybe accomplish the same thing as having to get to a pulmonary rehab center, which is why I like the whole body vibration device.
How does it work, doctor? How
does
it benefit?
It's not really vibration. So the plate can do either wobble, which is side to side, and you get to pick how fast it wobbles side to side, and it does it rather rapidly. It's not, seesawing. It really does move. And then you can get a sinusoidal where it does figure eights. And so what it does is it activates a part of our musculature, little tendon bodies, the little things that help to relay sense of where your body is in space and time. And it activates the muscles that are nearby, so that as you're moving through space and time, if the body feels that the muscle is out of alignment, it will contract it. So there's a large degree of muscle contraction that's going on that the patients don't perceive because they're not a body position sense to actually activate the muscles to reflexively contract. And so we've had folks actually break out into sweat. So don't get me wrong, you will start sweating, but not feel like you're running, which is rather, I think, an unusual phenomenon for some of our folks to early see was how much they were actually working out without actually feeling like they were working out.
Yeah, interesting. Thank you.
Dr. Robinson, this is Karen. Hi.
Hi, Karen.
I have severe osteoporosis in my lower spine. Would something like this, you think, be safe or not?
Well, that's one of those questions that we would often, and certainly with our musculoskeletal team, our physical therapists, we would look to see, because if you've got nerve entrapment as a part of any osteoporosis injuries, so if you've got neurovascular concerns, then we would always make sure that we've had it imaged first to ensure that, again, the compressions aren't going to get worse. As unless at least the doctors had a chance to make sure that, again, nerves aren't going to be further damaged, we didn't use it. But I'll be completely honest with you. We did, for a good number of our patients with osteopenia and osteoporosis, use the device. And so really it depends on how significant if you've got compression fractures. So imaging, that really is a telltale sign about whether it's going to make you feel worse versus better. But for our folks that had maybe one fracture in one location, lumbar located, thoracic is not quite as good in regards to so if you've got some thoracic fractures, we have one that unfortunately did have a little bit more back pain because she had to hold on, and so her back was being shaken while she was holding. But the lumbar spine is more stable. So depending on where your fractures are too, that's why I'm cautious to suggest it just without having imaging.
So it would be best for me to talk with my probably my PCP about it and see what she thinks.
Yeah, absolutely. And I think hopefully, and not every physician is aware of whole body vibration. But if she's had opportunity to send you to meet with a physical therapist, sometimes it's better to call the physical therapist, believe it or not, because they'll know a little bit more about your skeletal injury and be able to give you some recommendations.
Okay, sounds interesting. Thank you.
Yep.
This is Sue. What type of imaging are you talking about? X-rays or?
Yeah, sometimes a simple flat film. So it's an inexpensive film because the idea is, again, you always want to make sure that you've assessed whether there's a fracture if you've got discomfort. And then certainly if there is a fracture, making sure that none of the nerves that come through the spine are involved with the fracture.
What about thermography?
We now you're going to get into the nuts and bolts of what we would do. So yeah, we would oftentimes, instead of doing a flat film, send for an MRI scan. It gave us a lot more detail, but again, not every clinician is comfortable reading MRI scans, which means you're likely to, unfortunately, have to see a subspecialist in order to do so. So that was kind of the foundation of our office, was we had enough clinicians in-house that could do a good chunk of what 3 or 4 other subspecialists would be necessary for. So again, my goal wasn't to suggest seeing a whole lot of extra doctors, but to suggest that if you've got things that have already been done, to use what you have and make a determination of safety.
In my at the acupuncturist that I've gone to, she uses thermography where it shows the greens and reds and blues and that type of thermography.
Oh, I see what you're referring to. So heat therapy. I'm sorry, I thought you said tomography. I was thinking CT scan. Forgive me.
Oh, no, thank you.
Yeah, we actually did use thermography in the office, so we call it heat therapy. And radiation therapy is a wonderful way to not only relax muscles, but improve range of motion and treat pain. So yeah, that's a great modality.
This is Marshall. I'd like to ask you, I used to get asked, do you fall? And I used to always say no, but lately now I have been falling, and I was wondering about this, and I go to pulmonary rehab also, which is a godsend for me, but I've been falling lately, and I was just wondering if there was that vibration thing would help, or should I talk to my pulmonary people about that, or my doctor, or what do you think?
Yeah, so a huge part of our intake was we would do what's called a Berg balance test. A Berg balance test told us who was at risk, or more importantly, greatest chances that their activities of daily living were going to cause them to unfortunately end up on the ground. And so if your rehab hasn't done a Berg balance, I would ask them to assess your balance. I think the primary thing is you want to find out why it is you're having the falls first. So that, again, if it's musculoskeletal related, then that's easy. And I think the whole body vibration could benefit without concern. But you want to make sure, we've had some folks who had lost the sensation in their lower extremity. So that makes it a little cautious because they couldn't feel the platform. And so you want to make sure that there's no sensory cause for your falls before you hop up on the vibration device.
Of course, I suffer from neuropathy. I've had 2 hips and 2 shoulders replaced and things like that. And I am getting up there. You can see I don't have much white hair anymore, but anyhow, it's it's just a question. I was wondering if there was any thing that could help it. I mean, what do you do with people that have that problem of falling and stuff like that?
We spend a large amount of our time determining exactly what the source of the fall is. Again, if it's inner ear, so you've got some dysfunction of the ability to keep your head upright. My wife, her work was highly specific to body position. Sometimes falls are because you've got too much weight going forward, which means that you have to reposition yourself so that you're standing more upright. Some folks had weaknesses, so if you've had, like you suggest, surgery, sometimes the musculature on one side is stronger than the other side. And so we would spend time actually working to strengthen up the weaker side so that things were more even. So there's a little bit more work that goes into it. That's why I say for me, assessing what the source of the concern is allows for more focused work. And again, our office was a little different than most because that was kind of the foundation of what we wanted to do, was to answer your questions day one, which is we know why you're falling, and here's your added plan of care. So we did have folks who came to meet with our physical therapists outside of pulmonary rehab. So they came to the same facility, didn't have to go to a different location, but they met with their physical therapist, got whatever of those concerns addressed, and then went ahead to rehab after they got stronger. Or more
I know
importantly,
one thing I have is I'm always, when I sit in this chair like I'm sitting here right now, I'm leaning to the left. I've always done that. I don't know why, because it just aggravates me. And then all of a sudden I realize that I'm not sitting straight. And even on the bike or at the pulmonary, they used to tell me, sit up straight, Marshall. I thought I was sitting straight. Hell, I was leaning over.
well, I would have them walk you. So that was part of our gait assessment. So we did the Berg balance, and then we did a gait assessment. We watched how people walked up and down the hallway, so that some of the things that we didn't pick out, some folks had really good balance, but when they got walking, they teetered off towards the left like they were making a left. And so you only pick that out when we get people actually ambulating. And so I think for you that's just a couple of simple, not even more than 10 minutes really, of getting you up and making sure your Berg balance is normal, and then just having you walk in front of a clinician who can look to see if you're leaning, and then to determine if you are leaning, why you have the lean in one direction. My guess is, based on what you're telling me, if I had to, it's likely to be related to having some muscle weakness because of the surgery.
Mm-hmm. Thank you, Doc. I appreciate your input. Really do. Thank you.
You're welcome.
I have a question about the machine, the whole body vibration. If you have the vibration in addition to the balancing, is that correct? You are balancing different parts of your body while feeling the vibration. Is that it?
So yeah, what you're describing is probably absolutely the way it works. And so if you think of every amount of muscle between the back of the head, so the base of your neck, all the way down towards the tip of your toes, all of those muscles along we call the axial skeleton, all those muscles would get turned on like a light switch when you started doing the vibration. So each one of those small little muscles along the spine and some of the larger ones that attach to the spine, the little tendon bodies that I was referring to all light up like a Christmas tree. And when they do, they're going to turn on each of the muscles that supply them in order to contract, in order to keep you straight. So the idea is that your body's trying to counteract the vibration motion that it's feeling. And in that counteraction of the vibration motion, you're causing muscle contraction. And as you know, muscle contraction is how we get up and down stairs. And so we're just using the reflex of the Golgi tendon bodies to actually make your muscles contract without you actually having to do it yourself.
I'm reminded of a very primitive form of balance. When you're balancing on a ball, you're standing on like a board on a ball, and it wobbles, and you have to maintain your balance on that.
So
Do
this
you know?
works a lot. Yeah, so the cycles are a lot faster. So we're talking 60 revolutions a second. And that would be a kind of a medium speed. So 60 revolutions in a second, you can imagine how fast this thing is going. Obviously, for folks, we don't go that fast when they first start with the vibration. We would do maybe 15, 30 seconds, vibrations a second. And then again, we would probably do both. We would do the wobble where it would tilt back and forth, because that's a little different than the sinusoidal where you're doing figure eights. But it's vibrating while you're doing all of those motions. And so it's really putting a lot of the sinusoidals at 60 revolutions made people sweat, and you will break out into a sweat. And so we tried not to do more than 5 minutes at a time for some, and our goal was to get upwards of 10 minutes because it can be pretty taxing for some if they've not had those muscles awaken for quite some time. We did eventually have a gentleman who was on the thing for 30 minutes one day and scared the heck out of me. I didn't know how he made it into his car and got home. But your exercise capacities improved rather quickly, and I think he was indicative of that. Mm.
Doctor,
I wonder
Patricia,
too. I'm sorry.
go ahead, Carolyn. I'm sorry.
I'm wondering about the balance issue, the leaning to the side, because I know that I have scoliosis and I tend to lean to the side, and I feel like I need to strengthen those muscles to help me not lean to the side, but it is a curvature of the spinal column, so I don't know if the muscles can really be strengthened that much to help correct that.
There's actually good information about using whole body vibration in scoliosis. So depending on the Cobb angle, which is how significant your spine curvature is, if it's affecting your lung function, that's the best way I could describe your Cobb angle. So if your lung functions have been affected by how severe your scoliosis is, then that's going to take a little bit more manipulation. Work to help strengthen and straighten the spine first. But if your Cobb angle hasn't affected your pulmonary function tests, then you're likely to continue to strengthen those muscles on the opposite side of the curvature, so that it helps to pull you back straight. The whole idea is that while you're doing the activity, we have you look straight forward, and that automatically straightens the head and neck. So instead of looking down at the device, we've got a little dot that you have to focus on. The big dot that we put in front of some folks was a TV screen. But it gave them something outside that they could look directly at, so they weren't looking down or hunched over, but they had to stand upright, so that it forced the muscles to contract a little bit more while you're doing the activity. But again, we only did 5 to 10 minutes, so we didn't do a large, long period of time.
Thank you.
You're welcome.
I was wondering about combining that with yoga, because it seems that even chair yoga has been shown to have helping with an improved capacity for balance as well as flexibility. So
Tai Chi probably has, out of all the things we've talked about, Tai Chi has the best ability to affect balance and improve not just exercise capacity, but straighten the spine and improve the strength of the muscles that support the spine. So if I had to pick between the three, I would pick Tai Chi, just because, again, it has a larger amount of data than whole body vibration. Whole body vibration is the new kid on the block. And again, I like yoga because it's something you can do anywhere. And, in a good lifestyle choice plan, you would do all three. If I had it, to instruct, including all of the above, Tuesday, Thursday's Tai Chi, Monday, Wednesday is my yoga day, and Friday's my whole body vibration, 5 minutes watching whatever news service you like to watch.
there you go. Forget the news. Listen to music instead. It's less stressful.
Yeah, probably
Amen.
the only thing that's always on in the doctor's lounge. I don't know why.
Joe, I have a quick question for the doctor if we have just a minute.
Sure. Of course.
So, well, with winter coming and a whole bunch of snow here in Pennsylvania in the next couple of days, I'm curious if there's a temperature, doctor, that you feel is maybe too cold that asthmatics or folks with COPD should not go outside.
Ooh, that's
and maybe do
a
their
great
walking
question.
exercise.
That's a great question, because here in South Florida, we have a large number of snowbirds who moved down south just because as soon as the temperature got to 32 degrees, they felt their breathing was harder. Um, the best answer is that we know that cold air in some patients can constrict the airway, and when you constrict your airway, that causes more airway resistance. And we know that lung diseases like COPD are really founded in how much resistance is present within the lung, which is why inhalers are provided to decrease that resistance. And so, yeah, I think for some, depending on where and how their lung functions are set up, cold air just unfortunately made that constriction too great, so they felt like they couldn't breathe when they were in cold air. But I've seen the reverse, which is moist air, because again, you can make airway nice and plump in humid air. Probably not Karen; she's used to the weather down here in Florida, so I'm not worried about her. But for some folks, having humid air kind of does the same. It increases the plumpness of the airway, so not constriction, but swelling. And that a swollen airway causes increased resistance. And again, they felt like their breathing was harder in humid air, which is why my snowbirds in May start to move right back up north because it's cooler and not as humid. And so I think a lot of it is just finding the temperature that's comfortable. I hate to suggest people start moving all over to try and figure out, but I think the benefit of most of my COPDers were they were retired, and I told them to go check out the world and come back and tell me where you felt your breathing was the best. So go live life and then tell me where life was your breathing was the most improved.
Thank you. That would be nice to just travel the world and.
I'm looking forward to it. I haven't been on a plane in a year. I used to fly probably once a month, and not to be on a plane for a year is completely driving me nuts. But again, I don't mind. My family's healthy, so I'm not going to complain.
Thank God. Good.
I don't know if you have worked with any bronchiectasis patients.
Quite a few.
I have bronchiectasis.
Yeah, some of my favorite patients, believe it or not, are bronchiectasis folks.
How do you modify or what is different for them? Anything?
Yeah, so I hate to make suggestions for things we did in our office that may not be available in a large number of locations. But we had a good number of bronchiectasis folks, whether it was due to non-tubercular problems, some were fungal infections that caused it. Actually, a couple of our cystic fibrosis patients. We had a device called a phasotron. Again, I hate to throw out names of things that you may not be able to get, but a phasotron is a little cool device that you can give a nebulizer treatment through, and it pulsated. So it didn't blow air into the lung, it vibrated the lung, and it helped to migrate and mobilize secretions out of the lung of our folks. So we would often have our bronchiectasis folks come to the office a half hour, maybe 20 minutes before their PR sessions would start, and they would all, and everybody got their own cups, so we didn't share the cups with the phasotron. But they all got their 10 minutes of phasotron treatment and mobilized secretions before they got up and did their activities. And so is there another name for the phasotron? It's IPV, intermittent percussive ventilation.
Yep, you see Michelle's nodding her head, our respiratory therapist, saying, yes, that's what it is.
Okay. I knew there was another way to describe it. Again, it's not available in a large number of places, but it's an old school technology. I mean, it's not novel, new 21st century stuff. I mean, it's been around since even when I was a fellow back in the early parts of 2000. So, I think that's just asking around and seeing if somebody has it. They're common. I mean, again, they're not uncommon in some hospitals even.
How do you spell that?
Phasotron is PHASITRON. Joe, if you could help me with maybe sharing that information for us, since I stepped over that line and threw it out there. But you can give yourself a breathing treatment with it. So at the same time you're mobilizing your phlegm and any sputum that you have, you get a breathing treatment at the same time. And so it's comfortable. Comes in different we call oscillatory pulsations. So you pick the one that helps you the best. And again, we had folks come 2 days a week during rehab, and each day they came, they got a run on the phasotron to clear their mucus concerns.
So is it like?
Typical?
Sorry.
I'm sorry?
This is Valerie. I'm just wondering how that compares with the aerobica, because the aerobica is more widely available, and I know that we can use the nebulizer for our breathing treatments with the aerobica.
Well, it's the how this device works that makes it a little bit different. And so it's not just a nebulizer. In fact, you can use it without a nebulizer or nebulized therapy. You can use it just by the device itself. It's got two different levels of pulsation that it will provide. So it's not quite the same as Arabica, but it maybe accomplishes the same goal, and I think the idea that anytime you can mobilize secretions with whatever device and give yourself a breathing treatment at the same time, then you're really knocking out two birds with one stone. So, I mention it only because it's what we did in our office. I had it I hate to say that I had one. It was provided to me. I can't say that I bought it. But it was something that I think we found made a big difference for our folks with bronchiectasis, which is why I mentioned it.
Thank you.
Thank you.
Oh, you're welcome.
Patricia,
It would be a
may I-
device you go and use at an office or something like that. I mean,
That's right.
unless you have a few $1,000s hanging around, you got nothing to do with. It's a medical grade.
And so in South Florida, and again, Florida is different than a large number of places because we have a lot of retirees. Karen might actually be able to, so there's a home health agency, and so maybe some home health agencies in your area might have one. So we actually had a nurse-driven home health agency where they would actually take the phasotron therapies to our patients' homes. So if they'd bounce out of the hospital with an exacerbation and couldn't come to PR, rather than let them sit at home without therapy, we sent them with phasotron therapy for a month. So 3 days a week, the nurse would come with the device and do the treatments at home. So you have to ask. Again, it's a common device, but unless you've asked around, most people don't think about it.